Good evening, good morning, good afternoon, wherever you are in the world. We welcome you to our last event of the year, last but not least, because we have a great program for you tonight. I welcome you to the IVPN Migraine Masterclass. This is our 12th edition, and we have an excellent program for you today. Thank you for joining us. Just a few housekeeping remarks here. If you have a question, please put it in the Q&A section and we will get back to it. We have two speakers tonight and we will be taking questions after each speaker's session. So do put your questions and answers in the question and answer section of this program. This is the 12th intake or the 12th event that we've had this year. And it gives me great pleasure to tell you that we will be continuing throughout the next year with our Migraine Masterclass. This is in collaboration between IVPN, NeuroPsychiatry, and the Association of Migraine Disorders. And we aim to bring you migraine education wherever you are at a world level expertise with world experts from the region and from the rest of the world. Today's event is going to be on navigating headache emergencies from triage to treatment. And we will start with Dr. Alison McGregor, and then we will be taking the questions, and then Dr. Tawfiq Sadi. We give great thanks to our sponsor for this for this series, Pfizer. This couldn't happen without your generous support and continuous support to our educational events. We give you great thanks, and we are very grateful for you. So, without further ado, I will introduce Dr. Alison McGregor. Dr. McGregor is a professor of emergency medicine and currently serves as Associate Dean of Faculty Affairs and Development at the University of South Carolina School of Medicine, Granville. Dr. McGregor was the founder and the co-founder and director of the Division of Sex and Gender in Emergency Medicine at the Warren Alpert Medical School of Brown University. She has published over 100 peer-reviewed publications on biological sex differences and its impact on women's health, and was recently awarded an honorary degree in science by the University of New Hampshire for her life's work. Dr. McGregor is a published author and a very well-celebrated TEDx sensation, I think, with her talk on gender health and differences and women's health. Again, gives me great pleasure to have you today. We are going to talk about emergency medicine, but I'm also expecting a lot of questions around sex differences in migraine. And I encourage everybody to put their questions or to write their questions in the Q&A session. Welcome, Dr. McGregor.
Thank you so much. This is such a joy. We were chatting before we started about how great it is that we're having this much attention to migraine now. And so thank you to the IVPN and especially the Association of Migraine Disorders, who I've collaborated with on some patient-facing things. So this is like my business card, whereas this is kind of shows you who I am. And the reason why I'm here is to really sort of give you the perspective of going to the emergency department with headache from the physician side. How do we triage headaches? And so I've spent my past 2 decades seeing patients in the emergency department and researching sex and gender differences and being an advocate for it. And I've published a couple lay books as well as a textbook. And so you're right, I can't do this without talking about sex and gender differences in migraine, because that is the new evidence, that's the new research. So I don't even need to put it in the title, because just by looking at the evidence of migraines and treatments and and some of the biases in our screening tools, it's important to know that there are new research and new evidence base that take this into account. So just sort of making sure we're all on the same page, there was this basic assumption by science, by research, by medicine, that men and women were alike. In every way except for the reproductive organs. And so that was something that was why we studied men, and we, took that evidence and we applied it to both men and women. But it doesn't take long to come into my environment where we see the whole spectrum of disease. And the truth is that men and women do not present the same in many, many diseases and illness. We don't have the same risk factors. We have metabolism of pharmaceuticals that are different. We have different outcomes of disease. For instance, 90% of all autoimmune disorders are in women. Sudden cardiac death is 30 times more likely in men during exercise than in women. And then we have this migraine over here. And migraine has been considered a women's problem, a women's disease. And let's explore that a little bit. So it's important for me to start by saying that the differences that we now see in men and women are at the cellular level, the DNA. So our steroid chromosomes, sex chromosomes, XX if you're female, XY if you're male, these chromosomes are in every cell in the body. They are not just in the reproductive organs, and they're in the brain, and they really impact the way that our brain responds to pain and stimuli. And so that's really important for us to understand. It's also important for us to understand that every cell in our body also has receptors for estrogen, right? So our hormones. So there are hormone receptors in our brain, in our immune cells, and in our entire milieu. So considering these things is really the new wave of understanding evidence. And in the United States, since 2016, our major funding body, our National Institutes of Health, said that you must include sex as a biological variable in your application if you want to even be considered for funding. What that's done is really open up all this new evidence that we didn't really know that was there. And so it's a really exciting time. So when we think about coming to the ER with a headache, it's the fifth leading cause of ED visits. So a non-traumatic headache. So without having trauma, you go in and you complain that you have a headache. That leads to 3.8 million visits a year in the US. And that's about 2.8 visits percent of all visits. So this is not insignificant. And so let's just, think about this in terms of primary and secondary. So I know secondary is going to be talked about at a later time. But so when we think about a headache, we're thinking about the fact that the head is experiencing pain. So there's the trigeminal neurovascular system is stimulated. And what happens is it releases neuropeptides, and then those activate other neurons down the line. And so that is the primary type of a headache. When we are considering a secondary headache, we're saying that something else has caused that headache. A brain tumor, for instance. What are we going to see with the brain tumor? We're going to see neurologic dysfunction. We're going to see acute neuro effects. We're going to have different sort of pain during the day. When there's an infection source like meningitis, there's other signs. There's a fever. If there's a serious head injury, that's usually visible. The piece that's most important is when it is acute, then it's considered a concern for a subarachnoid hemorrhage, right? So that is not visible from the outside. That is where we have to really distinguish between, is this a primary problem or is this a secondary problem? And so when we think about migraine, I was asked to focus on migraine, obviously. And so when we think about it's the most common primary headache. It's usually associated with other signs and symptoms: the nausea, vomiting, photophobia, phonophobia, exacerbated by physical activity. Most of the time, there is an aura, and if there is one present, it's visual. And, it happens in the temporal regions. It's usually described as throbbing. And the time frame is 4 to 72 hours. And that's been quite consistent throughout a lot of the guidelines. And here's the problem. It can range from several attacks a month to less than one attack per year. And each individual can have many attacks at one point, and then, very few attacks at another point. The problem with being in the emergency department setting and seeing a patient that the definition requires understanding the episodic nature. And we only have this one point in time that we are assessing that patient, and that patient is describing a very painful process. So that makes it quite challenging. And so looking at what a primary headache is, most of the time in the emergency department, it doesn't always matter to distinguish between the three of them, because oftentimes they do react to the medications, cross-react to a lot of the same medications. But I thought it would be really important to just describe, like when we're talking about migraine, one of the major pieces is that looking at the additional symptoms. There's usually nausea and vomiting, as I mentioned with the other things. Whereas tension headache, there's really no nausea or vomiting. And a cluster headache, there's autonomic symptoms, so tearing and rhinorrhea and sweating. So that can be an important clue when you're seeing a patient. Also note that we have considered, like when we look at the incidence and prevalence of disease, we say that women are more likely to have migraines, women are more likely to have tension headaches, and men are more likely to be diagnosed with cluster headaches. So the bottom line is that migraine is more prevalent, it's more frequent, and it's more disabling in women versus men by up to 3 times. This is interesting. And some of this has to do with, obviously, the considerations in the different profile of either the DNA sex chromosomes or the hormone profile. And what's been really studied is the estrogen withdrawal hypothesis that initiates a migraine. But let's just look at lifespan. And the blue indicates men and the incidence and prevalence of diseases of migraine in men, and the pink are women. And you can see that very early on in childhood, boys tend to be diagnosed with migraine more frequently. As soon as you start getting to the reproductive years, that's when that incidence and prevalence really increases with women. And that persists throughout the lifetime, the lifespan. And you can always see, like for both men and women, as our lifespan evolves and our hormone levels change, that changes the prevalence of migraine. Let's look at this even closer, because when we think about hormonal, the hormonal milieu and the changes that happen during the menstrual cycle, we have seen this as an endometrial issue, that menstrual cycles give women periods, right? So we've looked at it from that perspective. And when we look at and compare the follicular phase and the luteal phase, if you just focus on the red line above, the estrogen levels, you can see as the estrogen levels go up, you have ovulation, and then they have a couple dramatic drops. And what we've realized is that it is those drops in estrogen that are stimulating the migraine, stimulating the headache and the neuropeptide release. But the visual that we usually use is looking at the endometrium so we can understand those fluctuations. But those fluctuations, the blood vessels, the inflammation, the response, the neurovascular, cycles are happening in the brain. They're happening in the heart and in the lungs and all throughout the body. So we have to really embrace this understanding of this fluctuation in all areas of what we study. So with this estrogen in mind, it's been thought that migraines are triggered by that rapid decrease during the luteal phase, right? And then if you look at women who have migraines compared to women who don't, and you chart their estrogen level, the faster the decline of estrogen during that luteal phase, the more likely they are to have the migraine. It's been shown that males have migraines also, and that's another biased issue because we have gendered this to be a problem for women only. But there's some relationship between the androgen levels and estrogen levels that are important to really embrace when you're looking at both sexes. And what's really interesting is that the number of migraines decreased during two specific times in a woman's life: during pregnancy, when estrogen is high, and during menopause, when estrogen is low. So let's look at that. This is estrogen levels throughout the trimester. And you can see that just once a woman is pregnant, her estrogen levels increase and increase. And this is where they become a lot of headache, migraine free. They're feeling good, right? And then what do you have as soon as you give labor, postpartum? That's when you have that dramatic drop, and that's when you have higher incidences. Let's look at menopause, right? So reproductive years, cycling estrogen, cycling progesterone. Perimenopause, very variable, right? So you may have really precipitous drops, you may not. There's some relief here, and then postmenopausal, your levels stay low, and then there is relief. So really, it's the change instead of, and it's the lack of having the steady state. So compared to males, females are more likely to have longer duration of migraines, more likely to have those nausea, vomiting, photophobia. That provides a greater disability because it takes them longer time to recover, and they're more likely to have recurrence of migraines than men. Here's the problem. It's a clinical diagnosis, and this is challenging to have happen in a quick environment like the emergency department, right? We don't have specific blood tests that can help us, right? Labs are not really helpful unless you get a beta HCG. So if you want to look to see if someone's pregnant, that's important because that's going to affect your treatment decisions. But also, because it's a clinical diagnosis and we have gendered this as a female's problem, our data is mostly retrospective, and it's mostly biased because it has predominantly included women. More women are invited to these studies because they're figured, oh, it's a greater incidence. Let me enroll them, and our data is incredibly biased towards women and against men in this particular example. And then there's actually no validated tools to use in the emergency department setting to diagnose a migraine. So the International Classification of Headache Disorders says, okay, you have to have at least 5 attacks. And that fulfills this criteria. So there's the time frame, 4 to 72 hours. And then you have to at least have 2, like unilateral location, pulsating, very severe, physical activity. And then you need at least nausea, vomiting, photophobia, phonophobia. This is really impossible to use in a one-time setting. I could ask them how many attacks they've had, but it's not very accurate. This is another one that has actually been validated in a primary care setting because it does use a one-time visit. So here but it has not been validated in acute care setting. So we could look at this as an emergency in the emergency department, but understanding that it has not been validated. So we could ask our patients during the last 3 months, do you have any of the following with your headaches? Nausea. Does the light bother you? Does it limit your ability? And so response to this are 2 or 3 questions. In the emergency department, we teach a mnemonic. A mnemonic is not a validated screening tool. However, we do use this, and it's called a pounding headache. So is it pulsatile? Is it the 4 to 72 hours? Is it unilateral, nauseating, disabling? You start to see some patterns here, but it's important to know if you're using these things as a clinical diagnosis, understanding the limitations. Why is that critical? Because there is a high risk of death. For instance, like I said, if you mistake a subarachnoid hemorrhage for a migraine headache, that has a much more high risk of death, right? And neither of them are, are visible, right? So like trauma is, or fever. Also, it's a high risk of death because migraines have been associated with cardiovascular disease. They've been associated with stroke. So, it's really important to understand that a migraine isn't just a migraine, that it actually puts that patient at risk of more serious conditions. So our biggest decision-making step is, when is neuroimaging indicated? Let's go back and look at this, right? So we have the primary, we have the secondary. It's when is it that acute condition, when do we assign it that we think it's worth to rule out and consider a secondary cause like subarachnoid. So the American College of Emergency Physicians has some recommendations. For instance, they have this critical question: in the adult emergency department patient presenting with acute headache, are there risk stratification strategies that reliably identify the need for emergent neuroimaging? And so the level of evidence, just to remember, level A is they reviewed the evidence and it's excellent. Level B, that it's good evidence. Level C, you start to get to not a lot of evidence, but expert consensus. So this is a level B, and the level B is saying that there's this Ottawa subarachnoid hemorrhage rule. So there's a rule that was validated, and it has a high sensitivity to rule out subarachnoid, a low specificity to rule it in. And that you have to use this if you are seeing the patient within the first hour of pain symptoms. Again, don't use any one single sign. So let's look at this. It's the Ottawa subarachnoid is for adults, anyone over the age of 15. And if you have symptoms of neck pain or stiffness, if you are age 40 or older, if you have a witness loss of consciousness, if this happened during exertion, either exercise or sexual intercourse, which I see, is it thunderclap? Is it peak in intensity? Or do you have limited neck flexion? If you have any of these signs, then you cannot rule out subarachnoid hemorrhage and you would move towards neuroimaging. So that is one step. This has been validated in emergency department setting and emergency department patients, and was found to be highly sensitive for identifying subarachnoid. But again, you cannot rule out subarachnoid with this. So another one, in the adult emergency department patient presenting with acute headache, does a normal CT scan performed within 6 hours preclude the need for further diagnostic workup for subarachnoid, right? And this is a level B again. And what it's saying is that if you do a CT scan within 6 hours of their symptom onset and it is normal, and they have a normal neurologic exam, then that is sufficient. And then you can consider diagnosing this patient with migraine without moving towards neuroimaging. Of course, you have to make sure you have a more up-to-date CT scanner. The other thing we use in the emergency department a lot are red flags. And again, these are things that get passed down. So red flags for headache are thunderclap onset, focal neurofindings, fever, trauma, altered mental status. A lot of these make sense, right? And so in the adult emergency department, it was still considered to be at risk after that negative CT. Is a CT angio as effective as a lumbar puncture? Again, this gets into a later, a more advanced a workup for subarachnoid, so not my particular focus. But again, shared decision-making, lumbar puncture, CTA are considered as effective. So let's talk about treatment. This is critical. And what's really important to realize is, as we start to think about treatments and medication, let's just review quickly the Ambien. Zolpidem is the another word for it. So what we learned from Ambien was on the market for 25 years or so, and it's a sleep aid drug, and it was primarily prescribed to women, even though it was primarily studied in men, because women were more likely to be diagnosed with sleep disorders than men. So what happened is, when you study men and you approve the drug based on those studies, and then now it's prescribed to women, the only time we can can really assess whether that there's adverse drug reactions is post-market surveillance. And so that's what we discovered with this. There were lots of post-market surveillance that said women were waking up the morning after taking Zolpidem or Ambien and then getting into motor vehicle crashes. Motor vehicle crashes are life and death. And preventing, any one of them prevents a crisis. So this prompted another look. And what they discovered is that when they gave women and men this drug and they waited the same amount of time, they checked the serum concentration of the drug, and women had 2 times the serum concentration compared to men. And so that was related to the fact that they had more concentration of the drug in the morning and then were more likely to have impaired driving. So this was the first Food and Drug Administration in the US sex-based dosing recommendation that men should be prescribed 10 milligrams and women 5. This is one medication. We have 20,000 medications prescribed, approved for use and prescription in the United States right now. So keep that in mind when we're thinking about our medication options, that a lot of this is going to be new evidence that we're coming to light. So let's look at a quick case. We have Erica, who's a healthy 24-year-old medical student. She presents to the emergency department with severe headache and nausea. She's had it for the past 6 hours. She had a similar headache once a term. It keeps her from clinical duties 1 to 2 days if untreated. After a careful history, physical exam, looking for all those things that we talked about, you decide she has a migraine. Why do you decide that? Because you checked the auto subarachnoid hemorrhage rule and she doesn't meet any of these criteria. You looked at your red flags. She doesn't have any of these. You're using your mnemonic for migraine and you discover that, yes, she meets a lot of these criteria. So you're comfortable saying that this is a migraine headache. And what is the best ED treatment for her? And so what we want to really consider in the emergency department is a lot of patients have already tried over-the-counter medication. Not only that, if they have migraine, they often will have the nausea and vomiting with it. So a lot of the first line treatments in the emergency setting are parenteral, meaning bypassing the GI system. So usually IV, sub-Q, IM, that sort of thing. And there's 3 main classes that are considered first line. One is NSAIDs, so the non-steroidal anti-inflammatory drugs, like ketorolac, which is IV. It has not been very well studied in this particular setting, but it has been found to be very effective, especially when studied, even as monotherapy. Triptans, very common, right? Our serotonin agonists. This is abortive therapy, and you can use it sub-Q or nasal. This is contraindicated in those with known cardiovascular disease, if they're pregnant or if they have stroke. And it's less effective if it's been going on for a long time. This is really good to give in the early stages. Interestingly, and I will bring this up again in a moment, is that the serum concentrations of triptans are higher in women than in men. And this is quite the case for a lot of medications and has to do with the metabolism differences. So keep that in mind. And females are more likely to have increased relapse rates after taking a triptan than men. And then you have anti-dopaminergic ones. So prochlorperazine, metoclopramide. These things are great for that gastroparesis piece, antiemetic, and it's also anti-headache. It is working on the neurovasculature. Of course, you feel sedated and you can have extrapyramidal symptoms like akathisia. So they're very restless. Diphenhydramine will reduce that, especially with prochlorperazine, not as much proven with Reglan. So this is really the first line that we have at our in our bag of tricks. Acetaminophen IV is not readily available. My previous institution I was there for almost 2 decades, and as soon as we started having acetaminophen IV, it was really incredible. I found it very, very effective in migraines and many other reasons. However, this is the one that's most commonly tried before the patients actually arrive to the ED. IV fluids. Now, think about this. If someone's had a headache and it's been going on for a while, they've been nauseous and vomiting, yes, they're probably dehydrated. Or if they were dehydrated to begin with, that's often a trigger for migraine. So IV fluids can be very effective if you feel as though this is part of the patient's presentation. And then there's Haldol and Droperidol. They find that when it's been looked at in clinical trials, that it's about as effective as placebo. And placebo is quite effective. So it's unclear whether it's related to just a placebo effect. And again, always have to look at risk factor profile, like QT prolongation, which is much more prominent in women. Women have a longer QT interval on average, and then they're more likely to be on lots of other prescription medications, which continues to increase their QT interval and increase their QT interval. So this is important to really consider, especially in women. Third line are opiates. They're considered less effective. There's greater disability. It's not an abortive process. It's more of a relief of some of the pain, but then there's somnolence with it. There's also increased likelihood of ED recidivism, which means that the patients come back and then come back and then come back. So this may be, still there are circumstances where this could be very helpful. We don't, this is up to our judgment. We don't want patients to be in pain, but we have to also consider with all of these, it's really considering the benefits and the risk. What I think is really interesting now is the addition of steroids, so dexamethasone. So there's an acute inflammatory process, right? You have those neuropeptides that are there. You are having a sort of depressed cortical stimulation. There's a depolarization, and then there's this depressant process, and all this neuronic activation. And so what's been happened is this discovery that actually giving dexamethasone does not necessarily help the acute phase of the pain, but it does help reduce the recurrence within that 72-hour period. So that's been critical. And then, this is so interesting that we're having all these new preventive treatments of migraine. Certainly things like estrogen, as I mentioned already, someone can be placed on hormone treatments or, birth control pills, oral contraceptive pills, or even other modes of delivery. Because remember, there are receptors for estrogen in the cranial vasculature, in the dura mater, in the different parts of the trigeminal vascular system. And remember, the consistency of estrogen levels reduces the incidence of migraines. So this is a really interesting thing that we, many can be discussed. Of course, the calcitonin gene related peptide, the CGRP, is fantastic. And I say fantastic because I'm not a neuroscientist, but I love the fact that we have other options that we're discovering. And why not affect that period where you have that neuromodulation, where you have the sensitization of the brain and the trigeminal system. And so I think that's critical. Some things that are also tried are topiramate, some anti-epileptics, beta blockers have been shown to be effective. So I want to just also say that the guidelines for acute treatment and prophylactic treatment are biased because they really don't address the sex and gender observed differences, right? We see these differences in treatments of Ambien, as you know, the flagship, and then triptan. So if we consider that there are differences, why don't we have recommendations for the dosing of these medications based on the biological sex or the gender identity of the patients, right? The only thing that's really sex specific is if it's considered a menstrual migraine, and then you could use really evening out the estrogen levels as a treatment option. But with all of those other treatments, it's not studied, and it's not discussed, but it's starting to be. Now, in the US, the Food and Drug Administration has the drug trial snapshots, where you can go online and look up a drug. Newly approved drugs are now being showcased on their website for transparency reasons. So you can say, oh, I was just given this new drug, this Ajovy, which is a new preventive medication. And you can see who was enrolled in the study that was used to approve that drug. And you can see that 87% of those that were enrolled were women, and 13% were men. So here's this, you know, these are the biases that we are living with, and we're understanding, and we're trying to really illuminate if this matters. What we need to do is make sure that we have sex-specific data, so that the data is disaggregated by sex and then compared. Because women, you know, they're more likely to seek professional medical advice. That women are more likely to encounter with the healthcare system than men. So with that, women are more likely to be prescribed. And so they're more likely to be prescribed preventive medications like a triptan. And they're more likely to have, you know, pain relief. But what's really interesting is that when you look at the metabolism of the drug, there are sex differences in the pharmacokinetics. What are pharmacokinetics? So it's how the body deals with the drug, and how the drug deals with the body. So it's really just a movement of that medication. And what it's been shown is that both the area under the curve and the total concentration of the drug of triptans are higher in women than in men. However, what's really also interesting is that may not have a lot of clinical importance, right? It's not just that. So this was really interesting research, and it looked at non-pharmacokinetic factors of variability of response to triptans. So even if women have higher concentrations, it may not relate to the clinical piece that we're measuring. But there are other responses that might be happening to the fact that the women have higher concentrations. Maybe it's having a difference in placebo effect by sex or gender. Maybe the course of the migraine is different between men and women, and therefore that concentration comes into place. And, you know, thinking about this also, it's important that we consider, are women taking contraception? Are women wanting to get pregnant? A lot of the, medications might be contraindicated, like valproic acid and Depakote are contraindicated in pregnancy. So it's really important to understand, what is the biological sex of my patient? What is the gender identity? How does that affect their presentation of disease? How does that affect the response to treatment? This was a nice, simple, bold study that said, this is a suggested prescription for severe migraine in the emergency department. Saline fluid, prochlorperazine, diphenhydramine, remember those two go together, an NSAID, ketorolac, and then dexamethasone to prevent return. So I thought it was worth, you know, it's hard to come up with, you know, when there's so many options. Erica got that. She got prochlorperazine, she got diphenhydramine and ketorolac and saline, and she got dexamethasone. And she's doing really well. And she got a family physician referral and some handouts. I was asked to just briefly mention status, which is when it lasts greater than 72 hours. Again, this is the art of medicine, right? So we have all of those options, and there are no direct standards, and we need to do our own research and to put this together. So when it's long, I did find this. This is a step-by-step suggestion that you can start with a lot of those first line ones to the second lines, a second dose of some of the first and second lines. maybe consider nerve blocks, and then consider opioids. So again, consider this is the art of the medicine. This is a very simple, quick case. 35-year-old male comes in. He said he's tried over-the-counter stuff. He really goes to the doctor. When he does have headaches, he goes to the emergency department. He gets IV dilaudid, and he feels better. And you look, and you saw that he's gotten that the past couple times, and he's starting to present frequently. So opiates are not considered a good idea and avoidable when possible. And actually, this study looked at prochlorperazine was more effective than hydromorphine for dilaudid. So I think it's really important. The American College of Emergency Physicians agrees that trying to use preferentially non-opioid medications is critical. I just want to point out where I get a lot of this information based on sex and gender. If you go to the website sexandgenderhealth.org and you go under the resources section, there's a validated PubMed search tool that looks at that will automatically put search terms into your PubMed, and then you can add whatever field that you want. So when I was preparing for this, I used this PubMed search tool. I added the word migraine, and now I have all of this really, if you look at the graph on the left and you see where the amount of evidence, look at the last 5 years or so, the amount of evidence that we're getting of sex and gender specific conditions in relation to migraine are increasing and are really interesting. Just a plug for direct to expert to physician is this collaborative effort, OM Health Hub, where we are collecting the experts in migraine. And if, I'm happy to bring some of you in on this, to direct to consumer, so that throughout the world, internationally, if you want to know sex-specific health conditions, especially related to your migraine, which is very common, as we know, you can go online and actually have a masterclass experience with the expert. So a summary, you can use the Ottawa subarachnoid rule to rule out the need for a CT scan. Don't forget the red flags. Try to use non-narcotics. Start incorporating sex and gender evidence into your area of expertise, and use shared decision-making. And I think I was nailed that time, although I probably took away time for questions, but I'll leave it up to the moderator, and I'm happy to answer any.
Dr. McGregor, thank you very much. This has been very informative, and we have a few questions, but I'm just going to ask you a couple of questions from your talk. I have, you talked about dexamethasone. What about prednisone? Any experience with prednisone, where it is more available in some of the countries that are listening to us today? Do you have any experience with prednisone? This is going to be more my own experience with this. Most of the studies are with dexamethasone because it is IV, and if you're giving that in the emergency department, also it has a longer action, so it will last up to 3 days. So it gives that one dose. It's one and done without having to put a patient on a higher dose or a taper. But if what you have is prednisone and they're able to take PO, I think that is entirely reasonable. And the other question I have is around, you talked about sex differences and estrogen. Do we have any predictors? Because I know we have a lot of patients that we go for continuous contraceptive or continuous estrogen, and they still don't have the benefit. Any predictors of who would benefit most from continuous estrogen or continuous contraceptive pill, in your experience?
I wish I get very excited, because now you're just like me, because yes, that should be something that we should be able to answer, right? But how many women are really, we now have apps that can track our menstrual period and cross over with migraines, and then have that discussion with a care provider. So we know that estrogen withdrawal is one trigger for migraine, but it's not the only trigger. So I think empowering women, patients, to really start to consider these things and to keep track of their menstrual cycle, keep track of their medications, what's working, what's not, and have these conversations openly with their provider, will lead to much more personalized and individualized care.
Thank you. I do have two questions that are overlapping, so maybe I bring them up right now, and that is on the antinausea. So we know that mostly we see more and more use of ondansetron. You mentioned metoclopramide and more the more traditional or standards versus ondansetron. Do you have any experience with ondansetron in the IV instead of using metoclopramide or prochlorperazine? Or
That's a great question. I find that it can be equally effective. For some reason, it's not part of a lot of the guidelines, but it's much more available. It has a greater safety profile. It doesn't cause the akathisia, and so I think when a lot of these things were looked at, they were also looking at which anti-nausea medications actually affect brain receptors that are cross over with the headache. And I don't know that Zofran has had that, but again, I'm not a pharmacologist. I would welcome another expert to speak on that. But again, I think this really comes down to the art of medicine and the QT prolonging profile. What other medications are they on? Are they allergic to things? And really just, taking a lot of that into consideration.
I totally agree with you. I think there were a few studies on the use of metoclopramide by itself as an abortive, and it does seem to offer some abortive properties. So maybe adding it increases our chances of success in aborting a continuous headache, because when they do present to the emergency room, they're not coming with that episodic. We're talking about a refractory headache or a headache that has been there for 5-6 days. So we do need to break it. So maybe that increases our chances of success. Someone did ask about also use of oxygen. I know we use oxygen in cluster headache. Have you ever tried it in migraine in your emergency room?
I have, because it's relatively low risk, right? So, especially, you start to think about it if they have the symptoms of cluster and you're like, oh yes, let's try that. I get very excited when they have that, because then I'm like, oh, where's the oxygen? Where's the non-rebreather? And I want it to work so bad. But yes, I have used it for lots of refractory ones. And let me just also mention that if you're in that sort of world of where it's really refractory and you're in that sort of status migrainous and you're really layering all these medications, consider admission. Because that really, it's time for that patient to be observed and supported, outside of the emergency department. Noisy, lights glaring, it's not the best place to be for a headache, especially if you have to wait in the waiting room. I feel so bad for these patients, but I have used it. I've not found it to be as an exciting therapy option. And usually by the time, if I'm using that with migraine, they've got 4 or 5 other things, going on at the same time. And it's hard to tell what to attribute it to.
I have another question here. Vyepti, the infusion CGRP, is this something that you use in ER? Is this something that you have started using in ER in the US?
No, not at all. I wish we could. I'm seeing more and more patients on those types of things for preventative. And there's injections and oral pills and this new nasal thing that I've seen recently. It's really not covered a lot by insurance. And so I find that that's kind of a barrier for patients to do as an outpatient. But in the hospitals that I've worked at, we are not there yet. It's not something that's available.
And the setup, I think, is that there's a certain setup that is needed that is not standard of care in emergency rooms, or do you think they can be just hooked up to a an infusion kit and they would be okay?
Yeah, I think it's the safety profile is really great. It's that I think with that neuropeptide, having that with the less side effect profile, having and starting it in an emergency department setting could also help prevent and be a great place if there's an allergy to it. So I don't think it's impossible. I think it's just making sure that the ED management, discusses this with our pharmacist to make sure that it's there and have protocols. I don't see it being, we do a lot of types of infusions like that, in the emergency department setting. So I would welcome it.
This is totally not within what you talked about, but I'm hoping that you'll be able to help me understand better mood disorders and migraine in the emergency room. Is there any other protocol that you do or any other intervention that you do provide for people who also live with mood disorders, depression, anxiety, any of those conditions? We know that prevalence or comorbidity does exist for this population, and add to that gender differences. Is this something that you encounter and you have pearls of wisdom that you can share with us on how to best manage?
So that is so challenging because of the dual diagnosis, as we say. So mood disorders could precipitate perhaps migraines, but migraines can also precipitate, the disability can precipitate the mood disorders. The emergency department is not a great place for mental health. I'm saying that, it's an unfortunate piece, but it's very true. So in order for mental health to really get its due in the emergency department setting, it has to be, get to the point where it's life-threatening. So I think we need to do a much better job of understanding how those things interplay and how we can better treat people who have both of those. I think in the emergency department, when people are depressed or anxious, benzodiazepines tend to be the go-to medication. And that may also, have a little bit of a relaxing effect for the migraines, but there's no seamless way to understand and treat both at the same time. A lot of this is just the art, as I mentioned.
On discharge, what do you discharge your patients with?
So most of the time, nothing from that particular perspective. So we used to discharge people on Fioricet to try to get them through, but then things like Fioricet, because of the barbiturate component, was considered in the same category as opiates, not very helpful, and it just increases the debilitation. So usually if I can get them to the point where they're like, wow, can I actually leave here? I would love to go home. Then make sure I've given them those steroids. To me, that steroid, especially Dex, when it's lasting several days, is hopefully their transition out of that 72-hour period. But other than that, sometimes, if they're young and healthy, I'll consider a triptan, but usually not as a discharge diagnosis. I think that's why it's important for them to follow up with neurologists. It's important for them to follow up their primary care doctor, because that's where you really want to have a more personalized approach to prevention. Usually, if we can get them to feel better, then then they're usually okay.
I mean, I'm a pharmacist specializing in migraine, so I see the after. They've been to Emerge, they came out, they're okay, they feel fine. That migraine has been aborted, but it's a few days later, and they're starting again to have the headache, and they feel like it would have been helpful if they were given something in Emerge so that if it comes back again. And usually, I mean, if they're diagnosed, if they have access to a healthcare professional that did prescribe something, they would get a triptan. And most recently, the Gepants have made it much here for us, because the side effect or the tolerance is much better, so they're able to actually take them and feel okay without having to be disabled for a couple of days by the headache. There was one last question around COX-2 inhibitors, and I know that in the US you have also just recently gotten a new, if I'm not wrong, it's celecoxib that is being used for migraine, or that is being trialed in migraine. Do you have any experience with that?
I don't.
Okay.
You mean in the emergency department setting, or just seeing patients that
No,
are
no.
on?
I mean, in the emergency room setting, do you at all use celecoxib, or do you discharge patients with that at all? I haven't seen it in Canada where I practice, but I've seen some chatter, and it's one of the questions that we have in our Q&A.
Oh, wonderful. Yeah. Don't have much experience with that, but I think that also relates to the previous question you asked, which is on discharge. It's I really understand that patient parallel, that problem of like, okay, now I felt better, and then it comes back. But we have to keep in mind that we don't really understand. We're in a focused patient relationship. So I have seen patients come in who have triptans that they take at home, that they get rebound with, and then they come in with symptoms of transient ischemic attack. So it's hard to just understand all of the risks for each particular patient outside of the particular emergency department visit. So, but again, not everybody has primary care or the ability to have follow-up. So I think the best way to do this is to have a system in the emergency department where you have these instructions, and you have good discharge follow-up, and make that part of a routine standard that is agreed upon by everybody.
I'm getting back again to estrogen and the pregnancy, and again hormones. There's a question around any recommendations about, you don't do this, I'm assuming, in emergency room, which is starting them on an OCP, or on for how long, or any of that. Do you discharge someone saying, do not have a break in your oral contraceptive pill? Is this something that is standard of care when you discharge someone?
Yeah, that can be a great discussion. And I think I probably have more of those conversations than an average emergency department, because
I would assume.
because I think of these things all the time. So I ask, women, if they're on hormone treatment, if they're on oral birth control, or anything, because I consider that part of their milieu. And so I have discussions with them about that in many different, perspectives, like for migraines, for seizures. There's a lot of conditions that cycle through with the estrogen, and it could, just having that knowledge base to empower that woman to try to maybe not do a breakthrough, or to at least have that. What I usually do is have them have that discussion with their doctor, like to give them that knowledge and say, here's something that's, maybe you should have this discussion because this has been shown to, to be helpful, or it's an option for you. And then they feel like, okay, I didn't, because a lot of times we ask, patients like, do you have any medical problems? No. Are you taking any medicines? No. I'm like, well, do you think you're pregnant? And they're like, no, because I'm on birth control. And it's like, we haven't made women think that this is a medication, and that it's,
Exactly.
it's important for us to kind of put into the whole
and if it's even more, and I see it again also in my practice more, if it's an IUD or intrauterine device, where they don't think of it as they're not taking a tablet every day. It's a device that is there for 5 years, so they stop thinking about it, and I do see some worsening while that is related to them having that, because it's progestin only, and that means that they're not supplementing with estrogen. Someone did ask about how does it work? Well, how does it get migraine better? It doesn't always, as we agreed, but it's something to try. And we know that the dip in estrogen usually can be a trigger or can contribute to headaches, but that's not only that, and that's the question. Pregnancy in the emergency room, if someone comes in pregnant, do you still give the same cocktail, or do you do any alterations? Do you do anything different for a pregnant woman?
Yeah, we definitely don't use as much poly substance. So we don't use polypharmacy as we start with the basic stuff with Tylenol. And honestly, this is an area that I also advocate for, is that we study medications in women. We have known things like I mentioned, the valproic acid and the topiramate, are contraindicated. So you recall that. But it's a lot of these decisions that are made, whether you give medications to women who are pregnant, become a conversation because they're not studied. When we enroll women into clinical trials, we are making sure that they're not pregnant. And if they do become pregnant, we kick them out of the study. And so a lot of these choices are just left up to the provider and the patient, whether they want to continue to take their preventive medications. There is no real random clinical controlled trials of this. So if I have any question, I always will consult, an obstetric specialist colleague, and they help, and we sort of take care of the pregnant patient together. I find that when you have a pregnant patient, it's important to consider the multi-specialty piece. We now have pharmacists in our emergency department, which is amazing. It's just really helped tailor care and to have that sort of specialty. So I bring a lot of people to the game. If someone is pregnant, I will make sure that we do the safest possible decisions. But there's also a call for more evidence for sure.
Thank you very much. I mean, I'm still seeing questions in the Q&A section, but in the interest of time, I will leave that to another event. But Dr. McGregor, you have really done a great job of introducing how and explaining to us how you manage migraine emergencies in the emergency room. We thank you very much, and we're looking forward to seeing you again in one of our events. This has been very useful, and I can see from the questions that it has been very, very interesting to our audience. Thank you very much. I wish you a great day. And again, we hope to see more of your great work. That I've looked at the work that you have been doing, and it looks unbelievably interesting for me as well, with the gender differences that we really, really need in migraine, and not only for women, but also for men who are left behind just because they are never thought of as candidates for the diagnosis. Thank you very much. Wish you a great day. I know you're starting the day in the eastern part, and we'll see you soon. Thank you very much.
Thank you for having me. This was thank you for bringing attention to this too. It's really important.
Thank you. Have a very good day. Okay, so again, thank you for everybody who's put their questions in the Q&A. I hope that I was able to, pass along as many as I can. We will try to continue to answer your questions. For the next talk, I have, of course, our very own Dr. Tawfiq Saadi, who I'm sure most of you know him, who will be presenting to us the latest research on what's new in preventive therapy, what is the newest evidence and clinical trials that are ongoing, and what do we know so far about the new options. To those who have just been introduced to Dr. Saadi, I mean, I've known him for years. Dr. Al Saadi is very well known in the region as one of our leaders in headache and epilepsy. And if you know about migraine, you know that migraine is the closest condition is epilepsy. So to be an expert on both conditions makes it even more valuable for us to hear Dr. Assadi. Dr. Assadi is Chief Medical Officer and the Chair of the Neurology Department at the American Center of Psychiatry. Years and years of experience, as I said, in epilepsy and migraine. He has served on the advisory board of the Northern California Epilepsy Foundation and on the membership committee of the American Epilepsy Society. He has previously served as the president of the Western Clinical Neurophysiology Society in the US and the vice president of the CIMA Commission of Eastern Mediterranean Affairs. He's currently the president of the Emirati League Against Epilepsy. And Dr. Assadi, there's not enough words for me to introduce you. I know that our audience knows you, they know you very well, because this is the second time that we have you, or more, I think, because you've also been moderating some of our events. Thank you very, very much. Dr. Assadi, if you can go to full screen, I would really appreciate it. We still see your slides. Perfect. To everybody, again, Q&A. I hope you enjoyed this second part of our session, and I'll leave the floor to you, Dr. Assadi. Welcome.
Good evening. Thank you very much, Dr. Hiba, for the kind introduction. I'd like to thank the organizers for everybody who had worked to put this together. I understand this is the last event for the year. And on that occasion, I wish everyone a happy holidays and happy new year in advance. So what I will be discussing in the coming 35 minutes or so, I'll discuss some of the new information that we have learned recently about the management of migraine. And the question here, we are probably at a new era in the management of migraine. And the question, are we there yet? This is a disclaimer, where my slide is actually my own, and this is my disclosure. And this is where I practice at the American Center for Psychiatry and Neurology. We have 4 branches, and this is the main branch that I work at, which is in Abu Dhabi. Well, wherever you practice, we know that migraine is a highly prevalent disorder. More than 10% of the general population would have migraine wherever you practice. We know that migraine is more prevalent than many other neurological disease states, including those with Alzheimer's disease, epilepsy, and multiple sclerosis. It's even far more prevalent than many other medical conditions, including those with diabetes, asthma, and osteoarthritis. If you look at the global burden of disease, we know that migraine is the second leading cause of years-lived disability. But if you look at those with the highly productive years, those from the age of 15 to 49, we see that it takes the leading cause of years lived in disability for those patients in particular. Well, this is not surprising to know that WHO have rated migraine along with quadriplegia, psychosis, and dementia as one of the most disabling chronic condition. Well, it's not surprising. We know that 50% of patients with migraine would have recurrent attacks severe enough that would require bed rest. Another story with migraine is the stigma related to the migraine. This is the data based on this observational survey study that was conducted in Europe. We see a third of these patients had suffered from discrimination as a result of migraine. But more importantly, for those who have this migraine stigma, related stigma, definitely have a negative impact on their social life, disability scores, as well as relationship and the overall quality of life. It certainly have a negative impact on several domains, including those with physical functioning, everyday activity, social life, as well as their emotional responses, frustration, mood swings, etc., are far more common in patients with migraine. It's not surprising again to notice that in patients with migraine that the quality of life is even worsened as compared to many other chronic disease states, including those with hypertension, diabetes, or coronary artery disease. The best management for patients with migraine is the integrated approach, where we have the non-pharmacological, the acute therapy, and the preventive therapy. Those had to be built in together in order to have the best outcome in managing patients with migraine. You cannot manage patients with migraine without addressing all these factors together in a holistic approach, an integrated manner, in order to have the best outcome in managing patients with migraine. Obviously, when we consider preventive therapy for patients with migraine, we look at many variables, the attack frequency, severity, but very importantly, how disabling the attacks are in order to decide if you are to start these patients on migraine prophylaxis. And there are several guidelines that had been available to us and guide us in terms of when to consider these preventive therapies. But the point here is when I make emphasizing on the attack frequency. There are several studies, and this is one of them, have clearly linked the attack frequency to the severity of the disease. Where you can see if in this study where 450 episodic migraineurs had been followed for 1 year, 14% of them had developed chronic migraine. And if you look at those patients who have what we call critical migraine headache days from 10 to 14, their odds ratio, the likelihood of them becoming into the chronic phase of disease is about 20 times more. So clearly the attack frequency is one of the most important predictor for the disease progression. And this is the data by Richard Lipton looking systematically what are the predictors of chronic migraine or progression of the disease. You can find the attack frequency is definitely one of the strongest predictor. Depression is another one, as well as the acute medication overuse. The problem is that at least, this is the data from the state, that 40% of these patients are candidates for migraine prophylaxis. Only 1 in 10 are offered that therapy. Well, obviously, until very recently, the problem with the previously available oral medication, half of these patients may not be able to continue or tolerate this medication up to 2 years. And you follow these patients up to 1 year, only 1 in 10 would continue on that preventive therapy. So in general, the adherence to these therapies were about 1 in 4 in about 6 months, and then 1 in 10 in about 12 months. This is based on the Italian cohort, looking at the retrospective population-based study, looking at the large cohort of Italians, more than 12,000, and look at the pattern of migraine prophylaxis using anticonvulsant, topiramate, beta blocker, antidepressants, or anti-serotonin agents. It's still, as you can see, that after several months, there's a significant drop on the likelihood of these patients continuing on treatment. And the question, obviously, do we need newer therapies to manage migraines? Obviously, we definitely need to, because these medications are expected to improve the quality of life in patients with migraine. Similar to the story of seizures, where we know seizures beget seizures, and migraine, we typically have the same story, where migraines typically probably begets more migraines, and there's a kindling phenomenon, so you need to definitely attack those as early as possible. And we know the story with the older medication. As I mentioned, good percentage of our patients may not be able to tolerate these medications and to continue on these medications for a long run. And that's where the story where the CGRP antagonists had become available to us in the past 10 years or so. Well, we know what happened during the migraine attack, where the CGRP serum levels are elevated. You infuse the CGRP, the migraine attacks can be induced. Triptans, which are the main treatment options for acute migraine, would definitely reduce the CGRP levels, which is concurrent with the pain relief. And the idea was here to try to find antagonists to the CGRP receptors or the ligand in order to attack the patients with migraine. Now, what we have learned over the years with these CGRP antagonists, well, we know that these are specifically designed for migraine prevention. They have very rapid onset of action as compared to the previously available oral medication, which takes months before you see an effect. They're very highly selective and target an important mediator in the pathogenesis of migraine. They have several therapeutic targets. They work on episodic, chronic migraine with and without medication overuse. They definitely reduces the use of abortive or acute therapies, low side effects profile, again, high responder rates, and require minimal or probably no dose titration. So clearly they have several advantages as compared to the previously oral medications. Now, how do these medications compare to what we used to use in our practice, what we used to call standard of care therapy? Though personally, I don't like that term, because I don't think there's anything standard about these medications, because we have used them for years, but we don't know really how do these medications work in patients with migraine, but those were the only available for us for many, many, many years. Well, if you look at the patient with episodic migraine, look at the 50% reduction of monthly migraine headache days. If you look at compare the data with the available CGRP antagonists or the MAPs as compared to the oral medications, if you're looking from this from the outset, the MAPs probably do better than the oral preventive therapies. Well, obviously, when we assess trials, we use the randomized controlled trials in order to approve these medications for regulatory bodies. But what we do rely on, especially when we assess the effectiveness of any medication, it's hands-on experience, the real-world evidence, or the clinical-based observational studies. Obviously, with the randomized controlled trials, the confounding variables are controlled. They're very highly costly to run, low bias, low generalizability, and low clinical relevance. Whereas in the case of the hands-on trials or in the real-world evidence, they're very telling trials because they reflect on our experience on the real world. Obviously, that comes at an expense of potential for bias. They're definitely less expensive, but they're uncontrolled, and they definitely are more telling probably than the randomized controlled trial because it reflects what we do in our day-to-day practice. So what we have learned so far from the real-world evidence on these trials? Well, the clinical trials look at several variables, look at the frequency, the intensity, acute medication use, and the disability, whereas on the daily clinical practice trials, we look at other variables, including the treatment attack, administration, tolerability, and other measures as well. Well, look at some examples of these real-world evidence. This is an example of the APPRAISE trial, which is the first global pragmatic 12 months prospective randomized controlled trial that had compared the effectiveness of Erenumab 70 versus 140 milligram as compared to the standard of care therapy. As you can see, this is a 100-center study that included 17 countries. After screening and 4 weeks of baseline, the patients were randomized 2-to-1 Erenumab versus standard of care, and then after 52 weeks, they went into the open label phase of the trial. If you look at the results, obviously patients on the Erenumab arm were at least 6.5 times more likely to stay on the initially assigned treatment as compared to those patients who were assigned to the standard of care therapy. If you look at the percent of patients completing 12 months on initially assigned treatment, was 86% on Erenumab as compared to 37.5% on the standard of care therapy. And if you look at the from patients' perspective, how patients perceive this treatment, again, you look at the percent of patients discontinuing treatment due to adverse event was 23% on standard of care therapy as compared to the Erenumab was almost 2.9%. So this is quite telling that what we see on the practice also being reflected by the patient's perception as well. And another trial, which is the Hermes trial, where the primary endpoint of that trial was the tolerability of the Erenumab 70 or 140 milligram as compared to the topiramate. Again, this is a double-blinded placebo-controlled trial. And after 24 weeks, patients end up on the open label phase of the trial. If you look at the result of the trial, obviously more patients would drop out of the trial on the topiramate arm as compared almost 3.5 times more likely on the to drop out in the topiramate arm as compared to the patients on the Erenumab arm. So basically, this is the primary input, and the secondary endpoint, which was the monthly reduction of monthly migraine headache days, was again patients on the were 2.76 times more likely to reduce their monthly migraine headache days by 50% or more with Erenumab as compared to the topiramate arm. Another trial which basically suggested that patients on the CGRP maps showed a higher adherence or persistence than those patients who were randomized to the standard of care therapy. This is based on meta-analysis. If you want to compare indirectly what we know so far from the episodic migraine arm as well as the chronic migraine arm, obviously patients who randomized or treated with the CGRP maps are more likely to stay on treatment as compared to those patients who were treated with the standard of care therapy. That was the case in the episodic migraine arm on the left-hand side, as well as on the chart on the right with the chronic migraines. Now, what about the GPANs? Obviously, this is a very different class, but they distinct class with a different profile than the MAPS in terms of the onset of actions, the half-life, and the target, because they only target receptors as compared to the MAPS, where they either target the receptors or the ligands, and they are small molecules. What we know about the GPAN, they work for both acute and in some cases they work on preventive, and rimegepant work for both acute as well as preventive therapies. As I mentioned, rimegepant was a distinct molecule because in the acute trial, it was noticed there's a trend of decreasing monthly migraine days with this medication. So it was tested later in a 305 trials, which is randomized controlled trials, which showed effectiveness, and that was led the FDA to approve this medication for prevention on the top of its initial approval as acute medication. And that was the case in 2021. Now, how do GPANs would be compared to MAPS, at least based on the systematic meta-analysis review? Clearly from this review suggests that MAPS and GPANs are probably equally effective based on, again, systematic review and network meta-analysis. This was the case until we had a very recent, which is only probably a couple months data that put head-to-head comparison between Galca as MAP example versus rimegepant for prevention of patients with episodic migraine based on randomized control trial. And the primary objective of the study was to assess whether Galca was superior to rimegepant in the prevention of episodic migraine. And specifically, the study was trying to directly compare the efficacy of Galca as compared to rimegepant in the prevention of episodic migraine. And this was the first head-to-head randomized controlled trial that had compared the two molecules in migraine prophylaxis. The primary endpoint of the trial was the percent of patients with at least 50% reduction in monthly migraine headache days across the treatment period. Again, it was a randomized, double-blinded, dummy active control parallel group. It was conducted across multiple investigator sites. It was about 75 sites in the States. The secondary endpoint was the mean change from baseline in the number of monthly migraine headache days and the percentage of participants with a 75% reduction from baseline in the monthly migraine headache days. And this is the flow chart of the trial. Included patients with 17 to up to the age of 75 with and without aura, had migraine for at least 1 year prior to their first visit. They screened about 1,467 patients and ended up with 580 who were participants of the randomization of the trial. And you can see that the completers across the two arms was around 260 across the two arms. But if you look at the primary endpoint of the trial, it's quite interesting that the primary endpoint showed no statistical significance between the Galca arm as compared to the rimegepant. And was basically, if you look at the responder rate, was about 62% with the Galca as compared to 61% with the rimegepant arm. If you look at the secondary endpoint, which is again 75% reduction, was more than a third of patients on Galca had achieved this outcome. Similarly, that the same thing, more than a third had achieved that same 75% reduction of the outcome on the patients who were randomized to the rimegepant arm. If you look at the safety, there was no safety signal, similar to what we have seen with the initial pivotal as well as the other real-world evidence trials between the two arms. So both of these medications were well tolerated with no safety signal of concern in both arms of treatment. So in the conclusion of that trial, that both Galca and rimegepant demonstrated efficacy as preventive therapy, with around more than 2/3 of these patients achieving the primary endpoint of the trials. Both treatments showed substantially improvement from baseline, but there was no statistically significant differences among the two groups. Safety profiles were shown in both of the two groups, similar to what we've seen in the previous trials, and the conclusion that there was no difference and both drugs were equally effective in migraine prophylaxis. But at the end of the day, I mean, okay, we've shown there's no differences in the efficacy. We want to have a drug that is effective, well tolerated, improving adherence, etc. But what is important is this: what is the patient perception? How do these patients liking their drug? So what we end of the day, we're looking at this patient satisfaction. We want to have patients that are satisfied with whatever drug we choose for them. And there are several ways to measure the satisfaction. This is the traditional way that we typically use in our market, where we can measuring the patient satisfaction. But there was a very recent trial that looked at the preference based on a survey, trying to explore patients' preference based on the availability of several novel preventive migraine treatments. Well, the idea behind the trial, because again, we care about the patient. There's always a patient-centered care model that we care about, and that should be, the patient's care should be the center of whatever we do in our day-to-day practice. I always emphasize on managing patients with migraine. Patients should be the core of our discussions. Patients should be taking the important integral part of the decision-making process in order to assure these patients would have the adhere to treatment and would have the best outcome when whatever drug we choose for these patients. So on this trial, basically the focus of this trial was to explore patients' preference for attributes of the CGRP maps, as well as the GPANs for migraine prevention. And basically, they use a different methodology. They use a discrete choice experiment survey, was the idea that was developed to quantify patients' preference for attributes of the maps, as well as GPANs for migraine prevention, and the potential attributes were considered. And this is an example of the choice task that had been shown to patients with migraine who had more than 10 migraine in the past 3 months. And you can see various treatment options, treatment A versus treatment B, look at the side effects, how often you have a migraine, and measuring the migraine severity, etc. And they used this model to try to understand how patients would perceive and liking their medication of a choice, and what are the attributes that they would take into consideration in terms of what is the best drug they would choose and would satisfy them for managing their migraines. As you can see, they sent out the survey for more than 10,000 people, and as you expect for any survey, more than 80% were non-eligible, and the people that had completed the survey was around 500 and was split between the States and Germany. And if you look at the results of that survey, that the most important attribute to patients was treatment effectiveness in reducing migraine severity. So patients had preferred a treatment that reduced severity to mild from unchanged. The second most important attribute was consistency of treatment effectiveness, because one thing that we've observed based on our experience with MAPS, there's always that fluctuation, and there's always end of the dose wearing off phenomena with some of these MAPS. And interestingly, the mode of administration and migraine frequency was similarly important, and patients preferred an oral tablet that had been taken every other day as compared to drugs that can be used monthly or quarterly for managing their migraines. And the preferences had varied between subgroups. Reducing frequency was more important for those patients with severe migraine burden, and consistency was more important to those with who tried on the monoclonal antibodies. Patients without such experiences valued oral therapy much more. And for in terms of the side effects assessment, patients were most concerned about 10% risk of injection site pain as compared to other side effects described, and side effects were the least important attribute overall. So in conclusion of that trial, obviously, it seemed that based on patient's perception, that patient had preferred a drug that showed consistency of effect, less likelihood of this problem of wearing off phenomena. They also had preferred a drug that had been dosed every other day as compared to drug that had been dosed either quarterly, intravenously, or monthly injections. At least this is what they found based on that survey. Now, finally, obviously, there are several ways we try to choose which drug and how we can decide on terms of how we can follow certain guidelines in managing patients with migraine. And obviously, the consensus statement or guidelines, one of the tools that we have looked at in order to try to help us to see where these drugs should fit into our armamentarium in managing a patient with migraine headaches. And we have recently developed our consensus statement, which was developed based on our own understanding of managing patients with migraine, plus on the international literature, specifically looked at the EHF guidelines and the AHS guidelines and tried to adopt our own guidelines based on these guidelines, which was published recently. And in our guidelines, we've came up with several statements, but the main statement that I want to share with you today, that for individuals with migraine who require preventive therapy, CGRP-based therapies, meaning that MAPS plus GPANs, who are GPANs that work for, obviously, the indication for preventive therapy, should be considered as first-line treatment options for migraine prophylaxis. And they should only be initiated by a neurologist. Initiation, not maintaining, should be initiated by a neurologist after meeting a specific criteria which have been modified from the AHS criteria. So just want to wrap it up. Obviously, globally, migraine is a very common neurological disorder. Migraine, unfortunately, remains heavily underdiagnosed and undertreated. There are still several unmet needs in management of migraine. MAPS, as well as which are the CGRP antagonists, are well tolerated, proven efficacy across the spectrum in those patients with episodic migraine, chronic migraine, with or without medication overuse, and definitely had provided some hope in migraines with, especially for those with unmet needs. GPANs are reasonable option to manage acute, and in the case of rimegepant, because that's the only drug that we have available in the market up to now that works for both acute and prevention, definitely have shown good effectiveness data and proven better patients' satisfaction based on the recent studies that we have seen so far. With that, I end, and again, thank you very much for your attention.
Thank you very much, Dr. Sadi, as usual, very informative and very enlightening. And I love the idea that we're looking much more closely at what patients want. And this is, I think, has always been a dissociation between what we were offering patients and thinking this is what they need versus what they really want. And the standards of care, what we call them the standards of care, the old medications, really missed all the aspirations and the requirements for people to not only abort the attack. It was not only about the attack. And I know in epilepsy, we were talking exactly the same. It's not just the seizure, it's the human being, it's the whole person. From your own experience, where do you think the priority should be in managing someone presenting to your clinic or for migraine based on what they need?
Well, again, you've put it very correctly, Hiba. It's every patient is different. And the only way we can manage patients with migraine is you have to listen to your patient. And if you don't listen to your patient and try to get a detailed history and look at all these variables, you're not going to be able to have the outcome that he or she would love to have, nor would satisfy you as a treating physician. Because I manage so many patients with migraine, and every patient has his own or her own history or story. And if you don't listen to the patients, you're not going to be able to nail it. I always emphasize you need to look at these patients from a holistic point of view. I've tackled some of these points, but there are so many other that I have not tackled. You've correctly mentioned those in the previous talk, the comorbidities. Patients with migraine, oftentimes they have many other comorbid conditions, anxiety, depression, insomnia, far more common in patients with migraine as compared to the general population. Trust me, if you don't address those, patient may not improve. Even if you put them on the best drug on earth, if you do not address these other points, you may not have the best quality outcome that you wish to have. So you definitely, again, to look at the patient from a holistic point of view, and each patient is different. I mean, I don't have a cookbook. I cannot tell you use one, two, I've mentioned our guidelines. Well, guidelines are good because they can probably help you and to to try to choose the best drug for your patient, try to help you in terms of defending your case if you want to present it for your insurance companies and in terms of your regulatory bodies. These are very good tools that you can have in your hand to fight your case before these bodies. But at the end of the day, patients may not basically fulfill the same thing that you look at in these guidelines. So the point here, every patient is different. I wish I have a cookbook, but every patient is different. And unless you address these patients' concerns, complaints, issues, you're not going to get the best outcome for your patient.
Thank you. And I love the idea of these are all tools. You still need the craftsman or the craftswoman or the person who is going to apply these tools. Patients' frustration comes from saying that we're not listened to. So I really love you starting by saying you have to listen, you have to understand what they really are, what are they experiencing, where their frustrations are, and try to address them in a on an individual basis. One of the things that we both saw in the last in the last Congress that we've just attended, the European Headache Foundation Congress in Barcelona, was talking about using the CGRP, monoclonal antibodies, and the GPANs in the aura phase. Is this something that you have also tried? I mean, I still think that I'm still not on the fence about this. So what do you think about this?
Well, obviously, we've seen the recent trial that we presented in the last European Congress in terms of using uprogepan during the prodromal phase, and I'll probably apply for other GPANs as well. The key here is obviously, as we always emphasize, try to use your best drug, your best tool that you have as early as possible. Obviously, with this trial, it emphasizes that these are migraine-specific medications. I mean, I'm so excited about the era that we are in right now, because we have a better understanding of the exact pathophysiology of migraines. We finally have the migraine-specific medications that can try to treat these patients. In the past, yes, we used to call these drugs standard of care therapy, though personally I don't like that term, because there's nothing standard of care about this medication, because till now we seriously don't know how these drugs do work, if they do. I mean, there are some speculations about how these drugs would work, but this is what we had. But now we finally had migraine-specific medications that had been developed based on our understanding of the exact pathophysiology of migraine. That's why it's not surprising, and the data that recently presented in the European Congress have clearly emphasized on that point. We have now migraine-specific medications, and you use Upro or use whatever GPANs, probably that's the same data could be applied on other GPANs as well, probably, because anyway, it was only studied for uprogepan, and it shows that drug, if you apply it early, it will definitely prevent the progression of the migraine attack. So again, emphasizing that these drugs are migraine-specific.
But we even have the same idea years ago with the triptans, that if you use them very early on, even during that prodromal phase, you might get better outcomes. But that never took on. That never actually, that was never adopted by practitioners. Do you think it had to do with the safety profile or the tolerability of these medications?
Well, again, I don't think we have a good understanding how the triptans work. I mean, obviously, some of the physicians, they use triptans, but they don't have really a good understanding of how triptans works. I mean, one of the ways that triptan works is they also work on the CGRP, by the way. I mean, now we understand how triptan do really work by working on the CGRP receptor. But the story of triptans, again, it's been available for us. But one of the problems with the Siftan, obviously, people had overreacted to the safety profile of the triptans. I still believe these drugs are safe, even in patients with cardiac risk factors. They're still, I personally believe, they're safe. Yes, you can use them with cautions, but I believe they are safe medications. It's always advisable to use them as early as possible, because that would guarantee your best outcome in managing patients with migraine. But again, the problem is we did not have a good understanding of triptans until we now got excited about the newer molecules. Then we went back and tried to analyze what we have learned from the story of the triptans, and things are evolving.
And and I agree with you. It's a very, very exciting time because of, for the first time in years and years and years, we have new data, we have new excitement, we have research that is all over the world. And I know that you are also part of this research that is happening. And again, we are seeing different diversity, let's say, because all the studies we used to have 30 years ago were very focused on European data, very focused in that small area of the US and Europe. And now we are seeing real world data on different populations that can give us insights as to how there might be some differences in how we react or how we respond to different medications. And that is the most exciting part, that we are today looking at data from Korea, and we're looking at data from Japan, and we're looking at data from the Middle East, Africa, and that is very, very exciting. Yes?
Well, actually, this is a very important point, because until very recently, we used, to rely on the data that comes to us from the Western societies, from the States, Canada, etc. But we did not have that much data coming from our region. I'm talking about, let's say, about the Middle East here. Until very recently, when we were quite privileged, now obviously with the access and accessibility of these newer medications, that allowed us to have an early hands-on experience with these medications, had allowed us to understand our patient in a much better way, and